Good afternoon and thank you. I thank the organizing committee, especially Dr. Sandeep Diwan, for having invited me here to be a part of this academic August gathering. So we are going to talk, I bring you greetings from Siliguri. This is the hospital where I work in. So we are going to talk on adjuvants in perineural blocks. I'm sure most of us are doing that and we are already using it. So what I will do is probably just present the evidence that we have for the use of adjuvants. The history of using perineural adjuvants dates back at least to 1892, when Bignon first described the potency of alkalinized cocaine when he added bicarbonate to cocaine, and he called it cream de cocaine because there was precipitation and the milky appearance. So we have novel perineural multimodal analgesics which introduce the potential to produce extended and enhanced quality of analgesia, and thus reducing the systemic opioid analgesic requirements after the surgery, as well as the potential neurotoxicity of local anesthetics that have been documented. And though the use of perineural catheters have increased, the majority of anesthesiologists still practice and perform single shot peripheral nerve blocks. So we have limited duration of analgesia of the local anesthetics, and the patients have pain for the first time during their first post-op night when they are most vulnerable after the surgery. So we have the adjuvants which increase the safety, quality, intensity, duration and the rate of onset, and the potential candidates for this are, we have clonidine, dexmedetomidine, dexamethasone, epinephrine, buprenorphine, tramadol, hyaluronidase, sodium bicarb, midazolam, ketorolac, and the list goes on. Even adenosine, dextrans. We have different additives used for extended and enhanced analgesia. We are talking about moderate prolongation of analgesia here. And we have slow release formulations, liposomes, Exparel and 300 milligrams of bupivacaine, which are probably being used for wound infiltrations, not for peripheral nerve blocks. So probably in future we might have something like that. Clonidine, we move on to this first drug which probably everybody, almost everyone uses. This is the unpublished data that we are conducting recently. Clonidine has been extensively analyzed, and we have this meta-analysis of RCTs by Popping, and he concludes that gives an analgesia of around extended analgesia for around 122 minutes, which is slightly over 2 hours, and has different actions with intermediate acting and long acting local anesthetics. We have a qualitative systematic review. Again, the same, improves the duration of analgesia and anesthesia when used as an adjunct, and the side effects appear to be limited when it is given in less than 150 micrograms. Various studies, some supportive, some negative for clonidine. This is the study from Dehradun which was published, and they have found the same thing. The clonidine significantly prolonged the duration of post-op analgesia without causing any adverse effect. They used only 75 micrograms. The effect of clonidine as an adjuvant to bupivacaine induced supraclavicular nerve block. This again RCT from Kolkata, and we have a prolongation of roughly 3.5 hours. The other studies, all RCTs, double blind, but evidence for use, having said all this, evidence for its use in peripheral continuous infusions is limited and probably doubtful. Dexmedetomidine, another potential candidate, and being used, causes a dose-dependent increase in the duration of both sensory as well as motor effects, extended post-op analgesia, and there are various literatures which are being published, but still, randomized double-blind prospective study again, this is from Pune itself, which compared both dexmedetomidine as well as clonidine, and they found dexmed to be better than clonidine. Sensory blocks using dexmedetomidine, 5.3 hours extra analgesia, that is what they get. Epinephrine, hardly anything, probably say an hour extended with lignocaine, but the part that I wanted to put here was there is no convincing evidence that epinephrine containing local anesthetics are causally linked to digital ischemia. Opioids mechanism controversial and limited data, though some support buprenorphine and tramadol probably. Opioids, 10 opioids, 6 supportive studies, 4 negatives, 4 systemic controls, 2 supportive, 2 negative. Clonidine, 5 supportive, 1 negative again. So evidence is limited and further studies of high quality are required before we can make any definitive recommendations. Dexamethasone. Now this drug has really come up very well and a lot of promising effects, and there are a lot of studies which are going on, and probably we have started using it. We will not deal with the mechanism, but then we have this extended analgesia around 18, 20 hours, 22 hours with dexamethasone. Varied dosages have been used, anywhere between 4 milligrams to 8 milligrams. Added to levobupropion, extended analgesia, 48 hours. This study is very promising with Fredrickson, which says that he conducted 2 randomized controlled trials of around 200 patients, and intramuscular administration, systemic administration of dexamethasone, 8 milligrams, and he compared it with perineural administration. So substitute systemic dexamethasone for perineural, minor analgesic enhancing effect, and with neurotoxicity reports, this administration needs re-evaluation. So we have again another article which was published in BJA this year, and the same thing, IV dexamethasone is equivalent to perineural dexamethasone in prolonging the analgesic. Now this dexamethasone, it's very conventional to use this intravenous, and if we are getting the same effect, then why not use it intravenous rather than do perineural, because the mechanism of action is, if it is having a systemic effect, then probably we can use it intravenous rather than use it perineurally. And having said all this, even if we have a sustained prolonged motor blockade, and the patient satisfaction score would be poor, and this would really matter, but may not be in those cases wherein if it is for a sensory nerve, saphenous nerve for example, or if it is for the brachial plexus wherein you have a forearm which is in a cast, so probably motor block would not matter that much. Or else if say we have done a sciatic nerve block and we have ankle which is in a cast, so probably yes, but then extended prolonged motor blockade. Current clinical evidence does not provide much support to the use of neostigmine, NMDA receptor antagonist ketamine, magnesium, bicarbonate, NSAIDs like ketorolac, midazolam and neostigmine. Now, effect of adjuvant drugs on the action of local anesthetics in isolated right sciatic nerves, wherein what was tried was combining clonidine, buprenorphine, dexamethasone, and they found that it acts by indirect mechanisms. This is in vitro studies, which says a single shot 0.2 milligram vial may increase the toxicity of lignocaine and presumably other local anesthetics. Ketamine has a direct additive toxicity, whereas midazolam has subadditive, and the pathway is mitochondrial apoptosis. Sodium bicarbonate does hasten, hyaluronate does hasten, but then it does not provide. So we have this combination wisdom, and we have this wherein a pre-treatment with alpha-2 adrenoceptic agonists attenuates the local cardiotoxicity and increases the hold. So this is where there is some evidence for its use. Looking forward to the use of anesthesia, and in the words of Salander, who said almost 2 decades back, correctly administered, I quote, correctly administered local anesthetics of clinical concentrations are safe, but animal data indicate that all local anesthetics are potentially neurotoxic. Given the complexities of pathophysiology of diabetic neuropathy and the complexities of deriving an animal model, it seems ill-advised to accept local anesthetics as the only potential anesthetic analgesic perineural option if other known perineural analgesic adjuvants are demonstrated to be non-toxic in animal models. So there are some recommendations that I would probably make while I conclude. Clonidine, say up to a maximum dose of 100 micrograms for an average adult. Epinephrine only is a marker unless if we are not using an ultrasound. Dexamethasone, encouraging data. Dexamethasone, extended analgesia, but potential response related neurotoxicity with local anesthetics. Buprenorphine, few support. Sodium bicarb, less efficacy. So what we need is a well-designed clinical trials, and with safety in focus in this era of ultrasound-guided regional anesthesia studies, which should aim to find options. Aesthetics. Vigilance is our motto. Supposed to be blessed, and to my place in rhododendrons, varieties of rhododendrons in the Sikkim valleys, and I welcome you to the International Pain Conference, which is going to be held in Kolkata in November this year. This is the first World Symposium and the International Pain Conference, yes. We can have registrations at the downstairs on the counter. Thank you so much for being here. Thank you.